So good evening, everybody. Thank you very much, organizers, for inviting me for this webinar series. And let me start talking a little bit about treatment of the radicular pain syndrome, disc herniation, and maybe a little bit of innovation for the pain management world. So that's my disclosure. I'm Max Moore, instructor for endoscopic procedures. And let's start thinking a little bit from the very beginning, because every time where I'm participating in any congress and if I'm giving a lecture about, let's say, mini invasive treatment of disc herniation and radicular syndrome, always the question about conservative management is coming. There are non-invasive specialties like physio and neurology, for example, and they are always in favor of conservative management. So when you go to studies about this, you will get a lot of results showing very good clinical management or no difference between conservative and surgical management within 12 months' time or more than 12 months' time. Maybe we can say that the conclusion is that surgical management is a good option for those cases in which patients have debilitating pain and need rapid pain relief, for example, because of sudden motoric or sensory loss. Maybe we can also agree with the evidence base, the results showing that in the long run, there is no superiority of surgery over conservative treatment. But then we also come to practical things like who has 1 year time to spend in a bed or to spend with the conservative treatment. And because people, they have their lives, they have to work, they have to make money, there is very few people really able to wait for a long period of time, and most or many of them, they really need quick action to come back to work, to make money, to support the family, and so on and so on. So that's why I think this need of conservative or surgical treatment is an individual thing. And we as medical doctors, we have to find the right answer when conservative and when surgical treatment is the correct option. There are more and more discussions about mechanism of resorption in lumbar disc herniations. And if you go to all the literature, you will find many mechanisms, descriptions, and situations when lumbar disc herniation can resorb spontaneously, which I fully agree with. Also, you see in your clinical practice that before there is any resorption and improvement of the X-ray image of the disc herniation, clinical symptoms can disappear much earlier than absorptions of the herniation happens. So it's very important to think and to realize and to keep in mind that there is very little correlation between magnetic resonance images and clinical symptoms. And that's why it's really a good idea to give the patient a chance to have a conservative management. Regarding reabsorption, I think it's very important also to know or to see what kind of structure is the herniation is having, if it's more hydrated, less hydrated, and then accordingly you are thinking about type of management. But the basic principle of reabsorption of absorption of the disc herniation fragment is that you are activating some kind of autoimmune action. There's secretion of special factors from macrophages, and those are actually somehow cleaning the epidural space from the fragment, and then the fragment, if it's not existing, is not causing any more inflammation and any more mechanical pressure on the nerve. This is actually the type of philosophy which is a little bit against the use of epidural corticosteroids, because epidural corticosteroids are working against the inflammation and against the resorption. But there also, if we go to this type of question, if we are supposed to use or we're not supposed to use transforaminal epidural steroid injection, this is still a golden standard with good clinical results. If we go to evidence-based, we see that we have quite good results with injections of corticosteroids. And again, from my clinical practice, I have to say that there is some kind of anti-inflammatory effect. And if the fragment is really hydrated, the corticosteroids are really supporting or helping to dehydrate the fragment to get him smaller in size. And this is also taking away the mechanical pressure on the nerve. So in some situations, corticosteroids are still helping the patients, and I would not say right now we are supposed to stop using them. Surgery. Surgery is a sensitive topic, of course. The question is, do we need a surgery for treatment of disc herniation, or if we need it, we go for full endoscopic, or we use a conventional microsurgical therapy. We have had this discussion with spine surgeons for many years. Despite many spine surgeons, they also perform full endoscopic approach instead of microsurgical therapy. I don't want to go into this because if you go to any type of literature, you will find that full endoscopic and microsurgical therapy is plus minus equally good regarding the clinical results. I think I'm not lying when I say it's correct on prime surgery, but when it comes to repeated surgery because of any reason that you have reherniation or more reherniations, if you use endoscopic approach, very seldom you will get any problem in form of post-laminectomy or so-called failed back surgery syndrome. And on MRI, even after 5 reoperations, you will almost hardly find the signs of any surgery performed on a patient. You will not see any muscle damage, and you will not see any fat degeneration of the muscles. So this is the difference between any type of open surgical approach and endoscopic approach. When you don't cut the tissue, you only dilate the tissue, and you don't damage blood vessels at all. To give you a little bit more information about endoscopic procedures in interventional pain management, it's not just disc herniation. We are able to do endoscopic facet joint ablation. We are able to do SI joint denervation. Of course, we are able to treat disc endoscopically, either if it's problem with herniation or if there is some kind of discogenic pain problem. And we still have in portfolio epiduroscopy for type of diagnostic or some treatment options within the epidural space. What is the inevitable part of indication process for any type of procedure, including endoscopic procedure, is a correct diagnostic loop. So before you indicate your patient for example, endoscopic discectomy or any type of discectomy, it's very important to collaborate with all the specialties being correctly involved in the diagnostic and therapeutic process. You are supposed to use the advantages of physiotherapy and so on and so on. And before you make your final decision about surgery, you have to be sure that you have done everything to avoid the surgical treatment. If it's not possible, you see on this simple diagram that this is only small part of the diagnostic and the treatment options we're using for people with radicular pain and back pain within this diagnostic and therapeutic loop for patients. I said at the very beginning that the first question when a pain physician is giving a lecture about endoscopic treatment of lumbar disc herniation is if conservative is not enough and if you need a surgical management. The second question always is if pain physician is as good or good enough or as good as a spine surgeon for this type of procedure? I've been trying to answer this question in different ways. I've been trying to advocate the pain physicians that we are used to do on daily, we're used to access on daily basis, foramen, spine foramen. That's why we are a suitable specialty to use endoscopes, transforaminally mainly. But then I decided that maybe to prove it, it's good to do a proper clinical study with the proper dates being collected. So we did clinical outcome of patients after endoscopic discectomy performed by two specialists. One of them was me, pain physician, and the second was a very experienced endoscopic spine surgeon from Germany. We compared our results and finally we published this article. You can find it easily. It was a lumbar spine herniations, mainly transforaminal approach. 12 months follow-up. We were evaluating leg pain, back pain, osseous disability index, relative risk of complications. We included 160 patients divided into 80-80 plus minus, pain physician and a spine surgeon. And then we did a minimum 1 year follow-up in the study. You can see the results before the operation, after the operation on leg pain, 1 year follow-up, back pain, 1 year follow-up, and osseous disability index, 1 year follow-up, and then complications. As you could see, there is no difference in clinical outcome of both a spine surgeon and pain physician. Both clinical outcomes are showing, let's say, excellent improvement of the clinical symptoms on 1 year follow-up. Regarding complications, also there is no difference, let's say, and there is a paradoxical thing that a duropuncture happened within the spine surgeon group, but it only once, and there was no consequence of this duropuncture anyway. Reherniation rate is similar, reoperation is similar. Overall percentage of disc reherniation was no more than 6.38%. So I can say the conclusion that it's an appropriate method for pain physician if he is, and that's very important to mention, adequately trained. Pain physician must manage intraoperative bleeding, of course. That's why you prevent postoperative bleeding if you are able to do it, but it's not so difficult if you know how to do it. Pain physician must manage postoperative complications, type pain, reherniations, duropuncture, discitis, wound infection. Pain physician doesn't need to manage maybe postoperative epidural hematoma or epidural abscess, because this is the complication which belongs to hands of spine surgeons or neurosurgeons. And it can happen also with epidural anesthesia. Anesthesiologists can cause it, or neurologists can cause it with lumbar puncture as well, using a diagnostic for diagnostic purposes. Risk of hematoma also is always spinal cord stimulators with other procedures. So that's what I would suggest. And I would like to give you a little bit more details about transforaminal approach, technical and anatomical considerations. Endoscopic transforaminal approach, I use a Maximor system because I like some special parts of it. I will explain a little bit more in details in the next few minutes. The good thing is wide range of indications. You can treat extraforaminal, foraminal, lateral recess, anterior epidural space, and posterior annulus problem. You need to be extremely familiar with anatomy of the foramen. So Cambin's triangle is your mandatory thing to manage 100% in details because you're working here. And what you see is also the part of superior articular process you are supposed to take away when you are approaching the foramen and going inside the epidural space. You need to know anatomy of the spinal ligaments within the foramen, blood vessels, and so on and so on. So you really need to be an expert in foraminal anatomy, which is good to know what you're doing, what you're seeing, and what you're dealing with. Then you need to plan your trajectory extremely well, because with endoscopy, if you don't plan the trajectory correctly, you miss the fragment and you will miss then the correct clinical result as well. So you need to know where the disc herniation is placed, is positioned. So if it's at the level of disc, above the disc, below the disc, then you need to know how to plan the trajectory. It's a little bit of joystick mechanism. The other thing is you need to know about posterior propagation, cranial, except for cranial and caudal propagation. So you need to know where it is in an epidural space, if it's central, paracentral, preforaminal, foraminal, extraforaminal, and then if the posterior propagation is grade 1, grade 2, and grade 3. According to this, you are planning how to deal with the herniation and with your trajectory and how to access it correctly. If you know this, then you're using some instrumentation. I really like what Maximor is offering in form of drills, manual drills or manual rimmers, where you can really you can safely land on superior articular process, take a little part of superior articular process, which helps you to open the foramen better for the future as well. So you're doing some kind of foraminoplasty. And then when you are accessing the epidural space, you're accessing in a very safe way because you are controlling with your optic vision where the nerve is. You're not going to the foramen before you are able to control the foramen with your optic vision. First, you access the bony surface of superior articular process. You have different type of geometrical anatomical calculations recommended with different type of expert in the world. My experience is the easier way to calculate your entry point is your MRI image, where you are able to know exactly where the herniation is, and you can calculate your measures according to the MRI picture easily and very effectively as well. Then if you have, for example, this type of herniation with a caudal propagation going behind the whole vertebral body, someone will tell you that it's not possible to access endoscopically. It is, it's just correct planning. You do the skin entry point, you go with the first instrument, you enter the superior articular process. You always check in AP and lateral position. You have a correct entry point, which is a crucial part. The Tom Sheedy placement is a special instrument similar to the bigger needle. If you correct Tom Sheedy correctly, then you do the whole surgery correctly. You access correctly the epidural space. You get your first instruments where it's supposed to be. And then you just go with drilling, your opening foramen with a couple of drills up to most often 8 millimeters. You're placing your working sleeve, and then under optic vision with a grasper, you are taking out your fragment. This is how your endoscopic picture looks like. So you have a very nice view. You see what fragment is if you know what it is, and then you're just like taking out your fragment. You're checking your epidural space. If there are no more fragments, you would like to see that there is a good pulsation of nerve structures and there is no bleeding. If there is a bleeding, you take care of it and then you close the wound. And this is your result. If you would like to know a little bit more about under endoscopy results, we have performed plus minus more than maybe 10,000 endoscopic procedures in Slovakia and Czech Republic. We selected plus minus 800 endoscopic discectomies for some type of evaluation of pain and quality of life analysis, and we did it in a minimum 1 year follow-up as well. We did all you see that we did it on lumbar levels, and then this is plus minus similar results I showed you on the comparison of spine surgeon and pain physician just on a bigger group here. So it was very good improvement of low back pain, very good improvement of leg pain, and very good improvement of quality of life with similar herniation rate we did in the first study. Here was more complex evaluation of the patient status after in a 1 year follow-up. We checked the mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And I think this is the group of patients you can see almost miraculously good clinical results, which is very satisfactory for pain physician in his job, where not everywhere you see those types of results. And then we have also some different situations, different indications I would like to mention. For example, scar tissue. There are a lot of discussions what you can do with scar tissue. It depends how much scar tissue you have. What is the clinical relevance of the scar tissue? This is a special case. The patient after fusion, as you see, with radicular symptoms, no MRI picture of any reherniation. So I went and did endoscopic revision of the foramen, which is not always possible, but very often it is possible. And then I got a picture of massive pathological tissue within the foramen. And this is not possible to manage with any type of catheter techniques or epiduroscopy. It's just mechanical thing where I was taking cautiously away the adhesion tissue, the tissue, pathological tissue from the foramen. And the final picture I got was the movement of the dural sac. When the neural structure started moving, pulsating, actually the patient suddenly, because it was under local anesthesia, felt a significant improvement of the pain problems, of the pain in his leg. And since that has been more than 5 years, and I can tell you the patient is still without any pain. So it's maybe the answer also if you ask me if this pathological tissue is not coming back. In 5 years, the patient is doing well and there is no problem so far. Then is another situation. If you have a look at this MRI, you can ask me what is wrong with this MRI. And I'm saying that there is a little pathology on L4, L5 disc, but the pathology is maybe not for surgery. It's not if the patient is not an elite Swedish cross-country skier with a need of a lot of training load, physical load, and if the back pain is not causing so much trouble with some kind of radiation into the leg that she is not able to perform her job, which is elite skiing. And again, there is a different type of presentation about discogenic pain maybe, but I can say that this lady, it's a different group of people, elite sportsmen, when they can have a combination of discogenic pain and radicular pain with very little MRI changes, and it's different type of treatment on such a kind of cases. We have a series of more than 20 elite sportsmen with similar MRI you have seen here, and we're collecting more and more data on this. And here we are doing some kind of transforaminal endoscopic approach with thermal annuloplasty of the disc and denervation, endoscopic denervation of the basovertebral nerve, with so far interesting clinical results where all our elite sportsmen came back to training. So this is another option, another type of management where you're not focused on a fragment, on a disc fragment, but you have clinical symptoms of back pain combined with some kind of radicular pain without proper correlation with the disc herniation. And it's also type of consideration what you can do instead of disc replacement and fusion, which is recommended as a gold standard. But if you use this type of management, like a radical surgical management on elite sportsmen, with the damage of the posterior compartment, of posterior muscle compartment, the person will never come back to normal sport, and the risk of complications in form of post-laminectomy syndrome is very high. And the question is, why to use such a big weapon on an MRI like this lady, for example, had. Another group is adolescent disc herniation. Adolescent disc, this is an MRI of one of my patients here. You see the disc herniation on the left side, L5S1 disc, with a correlation with clinical symptoms over 6 weeks, with a deterioration tendency, motor and sensory deficit, continuous pain, 24 hours a day, 7 days a week, worse at night. And the biggest problem was it was a young lady, couldn't attend school, couldn't carry on studies, couldn't live a normal life. That's one thing. The other thing is when you go to any type of literature and experience on adolescent disc herniation, you will find out that the resorption, because of different type of quality of the disc herniation, is a very low chance that it will resorb spontaneously. So you either need to do a surgical intervention, or if you leave it like that, there is a high risk of permanent nerve damage and permanent complications, which is not a good option as well. This young lady, she had a previous medical history of no trauma, no comorbidities. The only problem was she gained 20 centimeters in 6 months. She was referred to a neurosurgeon, no indication for surgery because of MRI. Finally, we did this percutaneous endoscopic lumbar discectomy, took out this with this type of final incision on her body, so she's still able to take pictures for any time of fashion job in the future if she decides so. But this is the result, and the same thing is 5 months follow-up. Now we have her on 12 months follow-up, no medications, no clinical problems, no pain. She's back to usual activities. So it's also a special indication to think about. Complications. I would say you can have transient paresthesia, which disappears within a couple of weeks. Intraoperative bleeding, you can see, but you can take care of it. Turasactyr, very, very seldom, but of course it can happen. Then, of course, there is a small risk of postoperative hematoma. Several cases of surgical instruments broken during the surgery. And of course, I think the biggest problem can be the infection, mainly the disc infection. So every year I have 2-3 cases of spondylodiscitis. And this is unfortunately impossible to avoid. I think if you say you do a disc job on a bigger amount of patients and you have never had discitis, I would say most people who say so, either they lie on numbers of cases they perform, or they lie on they did not have a spondylodiscitis, because I say, yeah, and I know all the spine surgeons or pain physicians dealing with disc job, they have 2-3 cases of spondylodiscitis every year. Unfortunately, it's impossible to avoid so far, despite you use antibiotics, prevention and everything. So this is maybe the most common and the most complicated thing happening in a hands where you don't know what you're doing. Of course, you can also perform injury of lumbar sacral plexus or aorta or abdominal viscera when you really don't know what you're doing. But this is very unusual complications, and I'm just showing it to emphasize that if you are dealing with this type of job, you really need to have an adequate training and perfect knowledge of X-ray anatomy and endoscopic anatomy to know what you're doing. Radiation is not a big deal as well, because on transforaminal cases, whatever you're doing, you're not exceeding 60 seconds of radiation time, and sometimes you really work with like a couple of seconds time. So if you know what you're doing, you don't need radiation almost at all. So let me conclude this lecture. I would like to encourage you to start thinking about this endoscopic procedures, to use them if you don't use them, and establish them into your pain physician's portfolio procedures. It's a minimally invasive procedure. You can do it under local anesthesia with or without sedation, depends on a patient. Very fast recovery. We normally do it on outpatient basis. Wide indication. You can take care of recurrent herniations even after open surgery. You can take care of extraforaminal herniations, which is not easy with open surgery. And also you can work with foraminal stenosis, discogenic pain, and sometimes synovial cyst if you need so. So it's a nice procedure, and I fully recommend it. And if you are not interested only in endoscopic procedures and endoscopic management, let me kindly ask you or invite you for our management pain series, where we would like to teach people advanced ultrasound pain procedures. And we also would like to introduce 7-star scope, which is a combination of endoscopic and ultrasound guidance, endoscopic guidance and ultrasound guidance for different type of pain procedures. So if you have nothing better to do in November, November 10 and November 11th, you are welcome to meet our international faculty in Prague. And even if you like beer, you can have an excellent Czech beer there. So thank you very much for your attention. And for the last picture, I have chosen a couple of pictures from beautiful mountains of Slovakia, just to show you how my country looks like. Thank you very much once again, and have a nice day. And if you have any questions, I'll be available to answer them. Thanks.